Hi everyone. This lecture will cover the child with an endocrine or metabolic alteration. The content of this information can be found in chapter 27. And I will review certain disorders such as diabetes insipidus, diabetes mellitus, and some other common alterations that you tend to see in children. So some of the differences in the endocrine system within the pediatric population is that it's the least developed system at birth than any other system, and that so the hormonal control of many of the body functions is lacking until the child is about a year to a year and a half of age. And infants, because their content of their body tends to be mostly fluid, manifest imbalances in concentrations of their fluids, electrolytes, amino acids, glucose, and trace substances. So that's why when infants have a compromise within such as something like infectious disease that's causing maybe some increased stooling like diarrhea, or they might even have a compromise within their skin integrity such as a burn, that their greatest impact for mortality is ensued to the fact of the imbalance of fluid and electrolytes. So these are some of the basic, we're going to do a basic anatomy and physiology review, and we're going to start off with the hypothalamus. And I really suggest that you go back for yourself to go through some of these key anatomy and physiological aspects dealing with endocrine. So the hypothalamus is located at the base of the brain, and it sends messages from the autonomic nervous system to the target organs. And so it's like what we call the master gland. It instructs the master gland to the pituitary gland. So it works in conjunction with that. And so that we know that it, through the secretion of releasing or inhibitory hormones, such as the thyroid releasing hormone or the corticotropin releasing hormone. And so the hypothalamus also deals with the growth hormone as well. And so that is the role of the hypothalamus. Now the pituitary gland, we know there's two parts, the anterior and the posterior, and it is the master gland. And so it's located beneath the hypothalamus in the base of the brain. And so the anterior deals more with the growth hormones and stimulates growth of cells, protein synthesis, and prevents protein breakdown. It also helps with stimulation for what you're learning in your maternity class. The prolactin, it stimulates the milk production in the mammary glands of the females. And so there's various, also the thyroid is another major one that it deals with, thyroid stimulating hormone. The posterior, which we'll talk about when we get into diabetes insipidus a little bit more, deals with the antidiuretic hormone and oxytocin, the pitocin, so stimulates the smooth muscles during contraction and the expulsion of the fetus and placenta, of course, during the birthing process. The thyroid gland, there's usually two lobes. There are two lobes in the anterior neck region below the larynx, and it produces T3 and T4 in response to the thyroid stimulating hormone for the pituitary gland. And so it's responsible basically for the synthesis of protein and cholesterol, glucose metabolism, heat production, growth and development, and metabolism. And then the parathyroid glands, there's actually 4 glands, 2 on each side of the thyroid gland. So it produces the parathyroid hormone. And so it increases the calcium concentration in the bloodstream by basically just stimulating the osteoclast in the bone to release calcium. So it helps with the release of calcium, increases serum calcium levels by increasing the absorption also of the calcium from the GI tract, and it also increases phosphate release from bones, increasing blood levels as well. So it inhibits the phosphate reabsorption in kidneys so that no more phosphate is excreted. The adrenal glands are located on top of the kidneys, and there's the two parts, the cortex and the medulla. The cortex, of course, produces steroids and the hormones made from the cholesterol. So you have your glucocorticosteroids and your mineral corticosteroids, your aldosterone. And so the other part is the medulla, which deals with the epinephrine, the fight or flight in the stress response. So it increases the heart rate, the respiratory rate, dilates the pupils, increases utilization of the glucose, suppresses digestion and immune system. And then you have your norepinephrine that's also involved with the fight or flight response, and the dopamine as well. Your pancreas, as we know, it has both the exocrine with the ducts and the endocrine function. So the exocrine secretes the amylase, the lipase, and everything that's needed for the small digestion or ingestion to help with that process, intestine digestion. And then the endocrine, the isolate of the Langerhans is also involved with the endocrine part. So it's the beta cells secretes the insulin. So that's where we have the insulin regulation, which forces the glucose into the cells and stimulates glycogen formation. And then we have the alpha cells, which work in the opposite manner as insulin. They break down the glycogen in the liver to increase blood sugar. And then we have our reproductive glands, our ovaries and our testes. And so with our testes, it produces the androgens, mainly the testosterone, and interstitial cells when stimulated by the FSH and the LH. The testosterone produces secondary sex characteristics in males, and of course we also know that it produces sperm formation and the actual sex drive. And then our ovaries produce the estrogen and the follicle cells, and so our estrogen produces secondary sex characteristics in females and mammary development. The ovaries and uterus, while pregnant, you guys have somewhat gone through this, okay, I'm sure in your maternal class, produces relaxin, which is a hormone that relaxes the cervix, the vagina, and ligaments around the birth canal in preparation for the delivery of a fetus. And then we have our human chromatic gonadotropin, so our HCG hormone is produced during pregnancy, and so it helps in the development of the embryo, and it inhibits immune response to the development of that fetus as well. So the first condition we're going to talk about several in this chapter, but we're going to talk about diabetes insipidus. And as I go through this, there's a couple of key things that I'm going to bring to light in regard to diabetes insipidus. So diabetes insipidus is considered a hypofunction of the posterior pituitary gland, and it's usually classified in two main ways. It's a deficient production of the ADH, the antidiuretic hormone, which is stored in the posterior pituitary gland, and it also has a lack of response to the ADH as well. And the ADH, as we know, acts on kidneys to restore water and control the amount of urine that is excreted by the kidneys. Now, there's two forms: the central or neurogenic diabetes insipidus, the production of ADH is insufficient, and then there's the nephrogenic diabetes insipidus, which usually occurs when the kidneys fail to respond to appropriate levels of ADH. Now, there can be a combination of both forms, and where there can be an abrupt onset and have similar manifestations of both. So some of the signs and symptoms that you'll tend to see clinical presentation, in fact, mostly for central, is you'll have some polyuria, polydipsia, enuresis, which is night bedwetting, getting up to drink water throughout the night as well, irritability. You'll notice that even more so in infants that really can't be relieved with feeds, and so we know that they'll have some poor feeds. And then there can also be some constipation, fever, dehydration, and hypernatremia. And then with nephrogenic diabetes insipidus, there can be polyuria, polydipsia, hypernatremia, diluted urine, vomiting, dehydration, and there can be fever and possible changes in the mental status. One of the biggest things that you will see is dehydration. And so these are just some of the signs and symptoms that I mentioned earlier on the other. And in particular, I have had them listed on here with the particular age groups that you might see some of these manifestations. So children of all ages may experience fevers, dry skin, and weight loss. And that seems to be pretty consistent. Diagnostic testing that's included is usually a 24-hour urine collection for daily output. They will do a serum sodium and see if it's elevated, if it's greater than 150 to 170 milliequivalents per liter. Urine osmolality is decreased less than 300. And then urine specific grav is decreased as well. It's usually less than 1.005. And then they'll do urine to serum osmolarity ratio to check on that. It's usually based also on a complete history, the physical examination, a daily log of their fluid and dietary intake. So strict I's and O's is something that you will need to look out for. Test for the urine specific grav, as I mentioned, in some of these other tests as well that's already been mentioned. So basic nursing interventions is just the recognition of the differences between the two. Now, I'm not going to have you guys go so deep into the differences between central neurogenic and nephrogenic DI. I just want you to have a good understanding of diabetes insipidus in general. But you do want to provide and encourage diet low in solutes. And basically, you also want to monitor for subtle signs of impending dehydration. Dehydration is the biggest thing. Dehydration is a critical effect of diabetes insipidus in the kids, and severe dehydration can occur very quickly, more so if we think about it in the younger kids, so infants and toddlers. And so we need to increase fluids as soon as possible, so these kids will also you'll see these kids getting frequent boluses of fluids. You as the nurse must be able to recognize the signs and symptoms of dehydration. And so just reviewing like dry mucous membranes, sunken fontanelles in infants, tachycardia. Just be on the lookout of that, knowing what are those signs and symptoms. Decreased tears when crying and poor skin turgor, so decreased skin turgor. Severe dehydration, of course, as we know, can lead to also hypovolemic shock. And so, as I mentioned before, the administration of IV fluids is essential to treat the severe dehydration, especially when the child can't tolerate PO intakes or by mouth feeds. So you also want to monitor urine output, fluid intake, document accurately, care for the child during water deprivation, sort of test, comfort the irritable child using distraction methods that are appropriate for that child's age. And then you want to administer certain medications. And some of these medications, in particular, DVAP is what we call it, desmopressin, it tends to be more commonly used. Now, I do want to go back to the water deprivation test, and I want to explain that a little bit. Water deprivation testing is performed to diagnose diabetes insipidus. So the patient is under direct supervision by you, the nurse, while you carefully monitor vital signs and weight. And urine and blood are collected early in the day and tested for osmolarity and electrolytes. And then the child is then deprived from intake of water until significant dehydration occurs. So then the child is usually weighed every 2 hours up until about 2% to 5% of the body weight is lost. So that's done intentionally. And then urine spec grav is monitored every hour. And this test is stopped once the urine spec gravity reaches 1.014 or higher. So the testing should never last more than 4 hours for an infant and 7 hours for a child. And during this test, vital signs are carefully monitored for signs of hypotension and for fever. Now, let's talk about vasopressin or desmopressin. Desmopressin cannot effectively treat the nephrogenic DI because the kidney is unresponsive to the mechanism of action of the drug, thus making it very important to diagnose the correct type of diabetes insipidus. Often this medication can be given intranasal, and it is commonly used for those, of course, as I just mentioned, who do not have nephrogenic diagnosis of diabetes insipidus. So that would be more of the central type of, I'm sorry, I apologize, that's more than just the nephrogenic. So the central type or the neurogenic, it definitely desmopressin can be used. So a lot of the education you're going to do is the importance of closely monitoring fluid and electrolytes imbalances, sort of giving the parents some signs and symptoms of what to look for. Encourage, especially in regards to sodium, what would you see? Encourage the family involvement for successful home management. So compliance is really big, giving the medication on a timely manner. You also want to teach about emergency care, involves teaching the parents about the signs and symptoms of dehydration and the need to take the child to the hospital for fluid replacement. So think of some of those common things you would think if a child is dehydrated. You would see some changes in level of consciousness. They would tend to have poor feet, listless a little bit more. That's more of a severe later stage. During the initial states of exacerbation of diabetes insipidus, it's important to teach the parents and child to increase fluids until the medication begins to take effect. And then often chronic home care involves teaching the parents of the child with diabetes insipidus the importance of the medication, as I mentioned before, compliance, and the correct way to administer the medications. As this is a lifelong condition that usually requires long-term use of medication for treatment. And it's also important for you to educate the parents regarding the importance of making the child's school aware of the condition and all those that the child has close contact with. All right, so that's diabetes insipidus. The next thing I'm going to talk about is syndrome of an inappropriate antidiuretic hormone. And this is where there's excessive amounts of ADH are produced and the kidneys are unable to conserve appropriate amounts of the water. So the body retains the water, leading to water intoxication and hyponatremia and cellular edema. So this is what you'll tend to see. Some of the clinical presentations or signs and symptoms. It's also called SIADH. It's very closely associated with children who have encountered infections of the central nervous system or intrathoracic disease, and it can also occur in post-operative patients as well. And so the signs and symptoms may have varying degrees, but it can of seriousness, but nausea and vomiting, seizures, headaches, muscle cramps, weakness. And so this makes sense since it involves infection, tends to involve an infection of the central nervous system. Excessive SIADH may include as well, besides these, some personality changes such as irritability, combativeness, hallucinations and confusion, and it can even lead to a stupor and coma. So you see that listed here. Other signs may include increased blood pressure, neck vein distension, crackles heard on the lung examination, weight gain with no external visible edema. And so because we have the cellular edema, you might not always see the child present in such a way as visible edema. Decreased urine output despite a high urine specific gravity and low sodium levels as well. So diagnosis is usually done through various diagnostic laboratory testing. And some of those tests include serum laboratory levels are monitored and diagnosed. And so they'll look for a high urine osmolarity, high urine specific grav, anything greater than 1.030, low serum osmolarity, anything less than 275, and then low serum sodium, less than 125, decreased BUN, and decreased hematocrit. Nursing care includes fluid restriction and is essential for a child with SIADH. The fluid restriction protocol, often hospitals will have it established, but may begin with restricting 75% of fluid maintenance and decreasing the fluids to half of maintenance if there is no improvement in 4 to 6 hours. So the emergency care of SIADH may include the administration of hypertonic sodium chloride solution, especially if the hyponatremia is severe and neurological disease is present. So you want to make the child's family members aware of the fluid restrictions and need for careful monitoring. So we're definitely going to have them on the bedside monitoring and recording strict I's and O's. Give certain medications with meals to prevent unnecessary fluid intake. Extra, you want to make sure that you're sort of like bundling that with their meals. You're going to irrigate all oral tubes with normal saline rather than water. Monitor the child's nutritional status, and they're going to have a diet high in sodium and in protein. Continually assess levels of consciousness. And so you're going to check for if the child is verbalizing, if they're able to verbalize headache. We know in a baby or a toddler, if they're not truly able to verbalize it, they may shake their heads a lot or even guard their head, um, and, and, um, and do certain activities like that. They may even be put on some prophylactic seizure medications. So you're going to watch for any seizure activity that can indicate severe electrolyte imbalance. Strict, as I mentioned, eyes and nose, diaper weights must be obtained from those kids who are infants, who are not potty trained, or who are bedbound. Let's see, some other things that you're going to do is, as I said, seizure precaution. So you should have all of this precaution equipment at the bedside. So some of the caregiver education also is that you're going to do is that you're going to teach the caregivers about emergency. What should they recognize the signs and symptoms of sodium depletion, such as weight gain, altered level of consciousness, confusion, complaints of headache, and irritability. And you're going to also teach them how to just, when they see those things, to take them directly to the emergency room. The importance of fluid balance is essential, so they have to know also as well how to assess intake and output, and such as fluid restriction using diaper weights. Often these families will receive a scale to weigh diapers, and or they'll have, it's for older kids, they'll have urinals or toilet hats to monitor the output. You have to also teach families, and usually a dietitian will also come in to teach the families, or a nutritionist, about hidden water in certain food sources such as popsicles. And so encouraging a diet high in sodium and protein is also indicated. And often these kids will also wear a medical alert bracelet. So just to explain about the how does this impact seizures? Low sodium and risk for seizures. Low sodium levels, of course, less than 125 milliequivalents per liter may cause seizure activity in children with SIADH. And so sodium levels should be as near to normal as possible, and this is the primary goal of treatment. Okay, so I just put this up here. I thought it's helpful. So as you go through your studies, just to see what are some of the main differences between diabetes insipidus. And sometimes with diabetes insipidus, they'll call it high and dry, versus SIADH, which is low and wet. And so some of the main differences is with DI, diabetes insipidus, they'll tend to be more dehydrated, where with SIDH, they tend to be more fluid retention. And with the natremias, you tend to see hypernatremia in diabetes insipidus, and then hyponatremic in SIDH. Okay, so next we're going to talk about conditions of the thyroid. And so we're going to talk about hypothyroidism and Graves' disease, which is associated with hyperthyroidism. So hypothyroidism tends to, clinical manifestations, you tend to see it more, most infants are born asymptomatic, and it often affected infants, about 10% have symptoms that develop within weeks to months after birth. And basically what happens is that the thyroid gland is underactive and secretes too little thyroid hormone for the body to function normally. And if left untreated, can lead to goiter's disease. Symptoms may include hypotonia, lethargy, open posterior fontanelle, open cranial sutures, umbilical hernia, prolonged jaundice, enlarged tongue, hoarse cry, constipation, dry skin, very dry skin, respiratory difficulties, poor weight gain, generalized edema as well. And often you'll see some decreased crying and increased birth weight and abdominal distension. So in infants, some of the bigger signs and symptoms include the larger fontanelles, as I mentioned, umbilical hernia, large thick tongue. And as the child begins to grow and mature, manifestations may include that they're having, they're shorter on the growth and development, so they tend to have shorter stature, delays in a lot of just overall growth and development of teeth, develop major delays in their developmental milestones. And often these kids will get labeled as what we call failure to thrive, which I believe we're going to talk about in our GI lecture. They'll also have a hallmark is puffy facial features as well. As they begin to grow and mature, some other manifestations, they may have some cognitive delay or mental retardation, protruding abdomen, umbilical hernia, thick, dry, scaly, pale, or mottled skin, and really dry, coarse hair, brittle hair. And some of the signs and symptoms as the child gets older as well, more overt or more like those found in adults. You'll see some of the bradycardic fatigue, hypothermia, facial puffiness, heavy or irregular menstrual cycles, especially in your late school age and in teens, and constipation. So diagnostic testing, they'll usually do thyroid labs are part of the state mandatory newborn screening, as we know. And in children with suspected hypothyroidism, they'll do T4, TSH, and antithyroid antibodies are taken. Thyroid scan or ultrasound may be indicated to confirm the presence of and position of the thyroid gland. And then the assessment of the infant or child's growth velocity may also indicate hypothyroidism, especially if there's like extreme differences between their height and weight percentiles. So nursing care is really based on the child's response to the illness. What is manifesting in this child? And then we move forth from that. Immediate initiation of thyroid replacement hormone is essential to prevent cognitive damage in newborns and infants. And then so also they'll do some newborn screening, follow up with newborn screening results prior to or at their first newborn visit within a week of age. And then we'll continually do some ongoing careful assessment of the height and weight on the growth chart to determine any growth delay. We'll also obtain history of the infant's activities level. So we encourage the family, the caregivers, to keep a daily log of activity level, feeding ability, frequency of feeds, bowel habits, and any of their visits that they make to their personal physician as well. And then we're going to provide a lot of family caregiver education regarding thyroid replacement therapy and medication administration. So you're really going to teach the parents how to administer thyroid medications by having them crush and mix the medication, usually with a small amount of water, breast milk, water, of course, for older kids who can take water. And I want to make that caveat. This is not for our infants, or breast milk, formula, or baby food. Instruct parents to give the thyroid medication at the same time each morning and not to skip or double doses. This is very, very important. So medication compliance is very, very important. You also want to instruct the parents that formula should be milk-based and not soy-based, as soy-based formulas can break down the effects of the medication. And reinforce the importance of medication compliance, as I just mentioned. And so you want to teach them about the contraindications, potential side effects that they would see of giving thyroid replacement medications as well. So, as I said, careful monitoring of the child's growth, weight, and growth and development. So that includes developmental milestones, weight. Instruct the parents. They're going to do during their regular follow-ups. They are going to draw labs for their T4 and TSH. Instruct the parents proper medication administration, as I just went over, and encourage the parents to seek early evaluation and intervention. That's just to curtail any future issues, especially if it's been diagnosed in an infant. If they're noticing anything different, to make sure that we're getting them on the right pathway. That there wouldn't be any additional cognitive delays or growth and development delays. All right, so Graves' disease. It's an overproduction of the thyroid hormone, so it's more of the hyperthyroidism. It occurs most frequently in teens between the ages of 12 and 14 and tends to be familial. Manifestation period of it is usually 6 to 12 months. Signs and symptoms, there are the identical to those of hyperthyroidism with the addition of 3 additional symptoms: goiter, enlarged thyroid gland, which may cause bulge in the neck and difficulty swallowing, raised thickened skin over shins, back and feet, back hands or face, swollen, red and bulging eyes as well. Some other signs and symptoms may include physical restlessness, fatigue, tachycardia, high blood pressure, increased perspiration, increased appetite, weight loss, difficulty sleeping, tremors, heat intolerance, fine hair, really fine, thin hair, systolic murmurs, absence of their normal menstrual cycles, and mood changes or irritability. And these are just going forth through some of these other ones. They might also have some sensitivity to light, eyes to light as well. So diagnosis, they usually do a serum T4 and TSH and thyroid to test the thyroid antibodies as well. They'll do an ultrasound of the thyroid. And then nursing care, usually you'll do a complete physical assessment, especially for those children who are referred for symptoms of attention deficit hyperactivity disorder. This is also often associated closely with Graves' disease. You want to do a complete school history of performance and behavioral problems, and their history of sleep patterns and changes in mood. With girls, of course, you want to get a good history of their menstruation cycle. Outpatient follow-up recommended every 4 to 6 months until everything is stabilized. You as the nurse must understand the administration, dosage, side effects, and nursing interventions of medications that are going to be administered for hyperthyroidism, for the goiters. Often they will do what's called this radioactive treatment as well. And so iodine therapy may be indicated to decrease the production of thyroid hormone. And in this case, you must be familiar with patient education and outcomes related to this therapy. And so often what they'll do is they'll place them in isolation. And you do a lot of bundle care where you take in items, you leave them in there to decrease exposure to the radioactive material. Some of the antithyroid medications are listed here, and so I would have you to look into these meds, learn just some of the common signs, some of the contraindications and side effects. I talked a little bit about the radioactive iodine therapy. I would like for you to be able to know about ways to decrease exposure. I might have a case study on your final question that deals about what would be appropriate care for a kid who's receiving radioactive iodine therapy. And beta blocking agents, Inderal to relieve the tachycardia, restlessness, and treatment, and the tremors as well. So have a good idea of things mentioned on this slide. So some of the education, you're definitely going to follow up with the parents and the caregivers and teach them about the importance of medication adherence. And even when they stop to see, often when people see signs and symptoms decrease, they sort of lack or get relaxed in their adherence. And so you want to say that might happen, but how important it is to continue with the treatment as ordered. The fact that they're going to continue to have routine blood tests done, follow-up visits and referrals. And you really want to promote a low-stress, low-pressure environment for these young people. And that's for all of us, anything, but it just exacerbates the situation. So we often will encourage the kids to even get involved with yoga. Some types of ways that they can de-escalate situations. Physically and even cognitively. It might be the fact of just counting back when they come up against stressors, 10, 9, 8, 7, 6, 5, ways that they can wind themselves down. So you're also going to teach the signs and symptoms of hypothyroidism in case the treatments become toxic, and provide emergency numbers, referrals, inform the school, of course, again, and teach the family to expect sudden emotional outbursts. That's not uncommon with these children. Okay, I had to get a drink of water, but now I want to go over the conditions of the adrenals. And we're going to talk about Cushing's syndrome and congenital adrenal hyperplasia. And so first, Cushing's syndrome. I actually took care of two kids earlier in my nursing career who had Cushing's syndrome. It's a result of the extended exposure to increased levels of cortisone, and especially you tend to see it in younger children. And most common causes are cortisol producing tumor, adrenal hyperplasia, and benign adrenal tumors. So chronic steroid use may also be a causal factor as well. And it's usually very hard to diagnose initially because the symptoms can take up to 5 years to manifest. And so, which is very interesting. So clinical presentation or some of the signs and symptoms will be weight gain. But like I said, they develop sort of slowly. They might have some alkalosis related to the hypokalemia and hypocalcemia, excessive urinary calcium excretion. Other symptoms include weight gain. They'll have what's called a pendulous abdomen, which is the weight sort of gains towards the midpoint of the abdomen. They'll have like a lot of fatigue, muscle wasting, weakness of the extremities. Round moon-faced, shaped face is very commonly seen with kids with Cushing's. And they'll have fat pad that's usually located between the shoulder blades, and this is known as a buffalo hump. And they'll often have like these stretch marks that are pink and purple on the abdomen, thighs, and arms. Now, cognitively, or really more so psychologically, the child may experience mood changes such as depression, anxiety, irritability, and have some form of euphoria. Growth delay may also be seen on the physical exam. And then again, females may have some irregular menstruation. Excessive cortisol levels may lead to hyperglycemia and in causing diabetes, high blood pressure, or arteriosclerosis. So the diagnosis is usually they're referred to a pediatric endocrinologist after a while, and they truly make the diagnosis. A 24-hour urine collection for urinary free cortisol is done, and then there's another test called 17 OHC, hydroxycorticosteroid test, that's what it's called, is done. They might do a dexamethasone suppression test as well. Saliva swabs to test cortisol levels. Serum blood levels of glucose, cortisol, and electrolytes. They'll do a bone scan to rule out osteoporosis because these kids are at risk for osteoporosis. And then MRI of the pituitary gland and a CT scan of the adrenal glands as well. So nursing care, the medical management varies depending on the cause. So steroid therapies may need reduction to lowest possible level needed for underlying condition. And so cortisol production inhibitors, if surgery is not possible, radiation therapy is often used. Now, if surgical intervention is needed to remove the tumors, because remember I said most of the causes are either steroid induced or by these tumors that are placed benign. They're usually tumors, adrenal hyperplasia, and benign adrenal tumors. Then preoperative assessments, fluid hydration, postoperative assessments is the regular trajectory that we would usually use for any pre and post-surgical patient. And then the medication regimens usually is cortisol replacements if needed. So nursing care, you're going to teach the family and the child about the disease, its cause and subsequent treatments and care that's needed. You're going to teach that emergency care involves educating lifelong cortisol replacement therapy daily and also in emergency situation. The patient will need to be taught about stress dosing with the hydrocortisone injections during times when the child is extremely ill, has a fever, is vomiting, experiencing trauma, or is going in for surgery, and how they need to make others aware of that, even like if they're going in for a dentist appointment and they maybe already have their wisdom tooth extracted. It's very important for others to know. Parents, you can imagine the child may go through some body images. Body image concerned. I remember the kids that I took care of, especially Anthony, he was really concerned about his weight and the way he looked in his face. And you have to reassure not only the child, but the parents that this usually will improve over time with treatment. You're going to offer nutritional guidance for healthy food selections that will help lower the weight gain, and instruct the parents, caregivers on the signs and symptoms of adrenal insufficiency, such as increased irritability, headache, confusion, restlessness, nausea, vomiting, diarrhea, abdominal pain, dehydration, fever, loss of appetite, and lethargy. These symptoms, of course, can be life-threatening, and if the parents should take the child immediately to the emergency room as soon as these symptoms are identified. Okay, our next one is congenital adrenal hyperplasia, which is also CAH. Inability, which is the inability to produce cortisol in the adrenal glands, and then excessive amounts of corticosteroid releasing hormones and adrenal corticotropic hormones. Hyperplasia of the adrenal gland develops, and then the end result is excessive androgen production from the adrenal glands. So with this deficiency, the negative feedback system fails, causing an excessive amount of corticosteroid releasing hormone to be secreted from the hypothalamus, and as well as the adrenal corticotropic hormone from the anterior pituitary. So there's basically an overproduction of the ACTH, which leads to overexcretion of the androgens. So some of the signs and symptoms that you'll tend to see, or the clinical manifestation, is approximately 75% with CAH are salt losing, so caused by aldosterone deficiency, and the other 25% will be non-salt losers. So the majority are salt losing. And in males, there are generally no manifestations until later in childhood, and these manifestations include early development of pubic hair, enlargement of the penis, or both. And then there's often advancement in growth velocity and advanced bone age compared to the child's chronological age. Often with these kids, you'll see a development of secondary sexual characteristics, which often will occur more so in the females. And the most noticeable manifestations occur with females as at birth. They will have abnormal development of the genitalia that is referred to as ambiguous genitalia. And this is when the clitoris may be enlarged and there may be fusion of the labial folds. And these manifestations can give the appearance that the female be male. However, the internal sex organs will be normal. So some of the other signs and symptoms of cortisol deficiency include weakness, nausea, as I mentioned before. They'll have cooling, clammy skin. Aldosterone deficiency includes vomiting, poor feeds, lethargy. I talked about Addison's a little bit and the importance of that. So the actual diagnostic testing is usually genetic paternal screening is available. However, the screening may show false positives results. So in this case, if that happens, you as the healthcare provider will need to evaluate for symptoms at birth. And then again, the serum 17 hydro test is done, but this one is the hydroxyprogesterone test, and it will be elevated. And if the levels continue to be elevated after birth, CAH is expected, as a normal growth and development will decrease the 17-OHP. So the more they'll mature, the more that this test will decrease. The result, the positive, it will start to decrease. In some cases, surgery of the genitalia is performed to meet the needs of the determined sex of the child. And you know, I am not going to go into this in depth right now. There is a lot that is being done on this. There used to be So let me say it like this. There's a lot being done in this field. UC Berkeley, Stanford, a lot of different major academia, healthcare institutions as well are looking into this. And this is why I believe we're starting to see an emergence of care being in adolescent health, spreading out to accommodate young people and helping them find their voice in this process. It used to be that the caregiver themselves would make the full decision. And many people, when they came into adulthood, felt that they were not given the option, but was forced to be of a certain persuasion of their sexuality, and yet they didn't embody that or feel that. There was a lot of people, as they became adults, also expressed through research that there was a lot of trauma that occurred to them throughout all the surgical procedures that was done. And so this is a field that is emerging. It's sort of falling onto the umbrella of the LGBTQI community as well, voicing and championing with this. And so healthcare ethical view boards, everyone is working together within the healthcare to look at better ways to serve this particular group of population with ambiguous genitalia. So some of the nursing interventions, that was just my little commercial on that. I wanted to share that with you. Nursing interventions, early diagnosis is key, basically to successful treatment. And you have to be able to carefully assess for pre and postnatal risk factors. They're often referred to genetics clinic, so they could do some genetic testing. Dehydration is often a complication of CAH, and so you as the nurse must assign for signs and symptoms of dehydration, electrolyte imbalance, and hypovolemic shock, especially when the 75% of these children are salt wasting. You're going to carefully monitor the cardiopulmonary status as well, and frequent vital signs assessment. You're going to assess the parent's emotional or the caregiver's emotional status related to the ambiguity of the infant's genitalia. And there's great systems that are in place to actually guide the caregivers, the parents, through this process. And understanding cultural and spiritual beliefs when counseling parents is also important. Provide detailed education regarding the cause of the diagnosis, symptoms, and available treatment options. And also, this is very important as well. If the infant's gender is questionable at birth, refer to the infant as your baby and not your son or your daughter. So don't put a gender particular assignment on the child, but refer as your baby. And if the parents have even named their baby, their child, use the name as well. So one of the things I want to talk about real quick too is the administration of corticosteroids and mineral corticoids. Emergency care involves education regarding the administration of lifelong medications, such as the corticosteroids. Emergency administration of corticosteroids given by injection should be taught to the parents for use when the child is in crisis, such as when they're having febrile illness, surgery, trauma, or severe stress. So the doses will need to be doubled or tripled during the period of crisis. And this is referred as stress dosing that I think I had mentioned earlier. So the most common medications administered are hydrocortisone and Florinef as well, which is mentioned here on the slide. So go through and just review these meds. Again, you want to explain that it's lifelong treatment, correct dosage, emphasize that if medication cannot be given at all, child must be taken to the emergency department or closest hospital. Advise family that the child should wear also as well a medical alert bracelet. Okay, so our next section is going to be metabolic conditions. And so we're going to talk about diabetes mellitus type 1 and 2 and diabetes ketoacidosis. Now, would have been the time that during the class I would have asked you to share your clinical experiences. If you've been at VMC, most likely, especially this time of the year, you have possibly taken care of a kid with diabetes. Halloween tends to be a very popular time right before and after, and then as soon as we hit Christmas, and then the other time of the year where we tend to see these school-age children tend to come in with newly diagnosed type 1 onset is when Easter, right in the springtime. So when we usually have Easter. So if you have any fascinating stuff to share with your peers, please do so. Feel free to do it. Okay, so diabetes mellitus type 1 is an autoimmune disease that arises when the child is of a particular genetic makeup and they're exposed to any precipitating event. Often what's interesting is these kids, and they're often school-age children, so usually you'll see these kids between the ages of 6 to 12 who will come in, and you'll hear the family said they had a cold a couple of weeks ago, upper respiratory infection, something like that. Some type of viral, and it has been known to be associated with other environmental factors and even certain foods. And then afterwards, they notice these classic symptoms: polyuria, polydipsia, weight loss, and muscle wasting and polyphagia. Of course, initially, you would tend to see the polyuria, polydipsia, and maybe even some weight loss. It's the most common form, type 1, of diabetes in persons less than 40 years of age as well. So some of the signs and symptoms of diabetes mellitus includes classic symptoms of wetting the bed at night, tachycardia, blurred vision, fatigue. Some of the younger ladies might have yeast infections, vaginal yeast infections. The following symptoms may be present as a keto acid accumulates: abdominal pain, nausea, vomiting, fruity smelling breath, of course, is hallmark. And then weakness, you'll see a deterioration in the level of consciousness and a lot of mental confusion, which can lead to coma because of the increased amount of glucose that's being retained. Slow, labored breathing, flushed cheeks and face. So those are some of the common signs and symptoms that you will see. You also see high glucose levels in the blood and urine. And you could see some dehydration as well. I don't know if I mentioned that. Dehydration is very common. That's why these kids will also, when they come in, they'll get boluses of fluids. Diagnostic testing. Diagnostics is based on elevated postprandial or random blood glucose levels. And so it's usually an excess of 200. An elevated hemoglobin A1C levels of greater than 7. They'll also have decreased serum insulin levels as well. Presence of serum and urine ketones. And of the affected individuals, about 85% to 90% may have one or more of the following positive autoantibodies. And you don't have to know this. I just thought I'd mention it. It's ICA, IAA, GAD, IA-2B is another one. But the most common that we'll look at is the decreased serum insulin levels, presence of serum and urine ketones, and then of course the blood glucose levels and the A1C level. So nursing interventions. Nursing interventions should focus on the following major areas. And first thing is physical assessment. What are you noticing? What are you seeing with the patient? And it's really based on eradicating that, whatever it is. So of course, if we are seeing that the child is usually with this, they do get boluses, they become dehydrated. It's going forth. What would you see with dehydration? What would you see with increase? And they're also having frequent urine output as well. What would you see with the increased blood sugar? And so you provide the care that is the medical management that has been ordered. All care is individualized and based on the needs of the child. There's, of course, as we know, no one child is alike. You're going to focus on monitoring and stabilizing and educating. And so as you're doing this, this is like in perfect synchrony in a sense. It's synchronized together. So as you're monitoring, you're also teaching. As you're stabilizing, you're also teaching the family. So the teaching is not like a one-stop shop at the end. It's from the time, even if the kid comes in with DKA, which we'll talk about in a few, you're going to do some teaching with the family as much as possible in bite-sized information ongoing. So the goals of the medical management is to have optimal glycemic control. You want to make sure that there's ongoing normal growth and development too as this child begins living with type 1 diabetes. Minimize complications and attainment of emotional adjustment to the diabetes as well. So the teaching is teaching parents to evaluate for the signs and symptoms of hypo and hyperglycemia, emphasizing the proper diet, exercise, and stress management. You're going to instruct on the monitoring of the blood glucose and ketone levels, and teaching about types of insulin and how to give the injections. So I'm going to talk a little bit about some of these types of insulin real quick. If you're given insulin Lispro, so usually the onset's 15 to 30 minutes. The peak is usually almost 3 hours. It's 2.8 hours. And the duration's for 24 hours. And so the route, of course, is sub-Q. And if a patient's in DKA, I want to say this as well. A patient who's in DKA, only regular insulin may be used, and it has to be used intravenously during the management of DKA. So that's something important to remember. So insulin aspart protamine suspension, the onset's 15 minutes, the peak is 1 to 4 hours, and the duration is anywhere from 18 to 24 hours. And then MPH, regular insulin, mixtures, the Humulin 50-50, Humulin 70-30. The onset is 30 minutes, the peak is 4 to 8 hours, and the duration is 24 hours. So let me go back to this real quick. So I want you to think as you go through this, you're going to think about how would you do the teaching with the family. You know, what are you teaching them, the signs and symptoms to look for? Medication administration. You're also going to teach them about stress management or sick day rules, which I haven't talked about, but it should be established and taught to the patient, the parents, the family members, the teachers, everyone who has close proximity, even if it's a daycare, they should learn how to do that and manage the sick days. And so there are important things like rules about that. They have what's called MDC BHF. So you're going to monitor, the M stands for monitor the blood sugar levels more frequently. D stands for do not stop taking insulin. C stands for check urine for ketones. B stands for be careful with over-the-counter medicines. H stands for have a game plan and don't hesitate to call any provider or nurse for help. And F stands for force fluids. You want to teach the parents how to inject the insulin as well. So you would do return demonstrations. You would talk them through the process. So you would talk them through the steps, such as checking the expiration date on the insulin bottle, preventing the spread of bacteria by washing their hands, clean rubber stopper on the insulin bottle with alcohol, remove syringe and cap, pull air into the syringe, line up the end of the black plunger. So you want to go through all the steps that are needed as well. And often what we'll do before they go home is that they have to do the actual return demonstrations on their child. Sometimes what I have noticed in practice is that depending on the age of child, even if the child's 6 or 7, they tend to be the one to want to do it because they want to have control. And so yet the parent might draw it up. The parent might feel like, I can't do this. I have noticed that parents couldn't do it, but the kid could, which is amazing. So it just depends on the child. Okay, so type 2 diabetes is characterized by the body's resistance to recognizing and utilizing insulin. And so type 2 diabetes is usually labeled as adult onset, but it's sad to say that an alarming increase is happening in young people, and a lot of that has to do with the overindulgence in processed foods and underindulgence in physical activity. A lot of programs of schools have been cut out as far as physical education and other things that used to promote running and playing and stuff as such. So signs and symptoms often, of course, we know this is often asymptomatic until a routine level is done, exam is done, and you'll see that their blood glucose levels are pretty high. And then, or if there are some minor complications, often if the child is larger in weight, then their developmental age range, they'll start doing some glucose checks and maybe even check A1C as well. The kid might start to complain of when they might have had no problems prior, of blurred vision or poor vision. They can't see the chalkboard or the teacher's notes as well. They're being put up on PowerPoint. It can lead to being impotent, fatigue, poor wound healing, numbness or burning sensation of the feet, ankles, and legs. Of course, I mentioned obesity, unexplained weight loss all of a sudden, headaches, symptoms of sleep apnea as well, because it's usually due to secondary of the obesity. In some cases, symptoms may mimic those of type 1 and appear more abruptly. So they might have the polyuria, polydipsia, the nocturnal bedwetting, yeast infections, and whole body itching. So type 2 diabetes, in 2013, the ADA established criteria for type 2 diabetes testing in children. And so with that, overweight is defined as one of the following. The BMI is greater than the 85th percentile for age and sex. The weight is also 85th percentile for height. Greater for height. Weight is greater than 120% of ideal weight for height. And some other risk factors include family history of type 2 diabetes in a first or second degree relative. So that would be the actual parents, sibling, that would be even grandparents. Race, of course, plays a huge issue as well. Native American, African American, Latino, Asian American, and Pacific Islanders. So diagnosis, we call what's +2 of the following risk factors. So insulin resistant or condition associated with insulin resistance. So you'll have some hypertension, dyslipidemia, polycystic ovary syndrome, or small for gestational age birth. Maternal history of diabetes or gestational diabetes also places the child at increased risk. And this is usually confirmed by fasting glucose results that are greater than 126 or 2 random blood glucose readings greater than 200. So care is really, it depends on the developmental age of the child and the family's response to the diagnosis. You're going to monitor for complications. We know that this is all dealing with lifestyle and management of that lifestyle. And so some health centers or families are really good. Providers are very good at connecting the families with ongoing clinical nutritionists or community programs that assist in behavioral modification with diets, foods preparation, exercise programs, stress, ways to decrease the stress levels, all of that. So you're going to promote compliance to the medications as well, and to prevent any further other complications. So you're going to give them signs and symptoms and tell them how infection could be can actually exacerbate their diabetes mellitus type 2 as well, the same as what you would find with type 1. You're going to communicate with other professionals about child's individual needs if it's needed. So that means other members on the interdisciplinary team, such as clinical nutrition, probably would even get social work involved, possibly if they need connection to some more community resources and support systems. You're going to teach the diet management, decreasing caloric intake, even just trying certain diets that are less processed foods, such as paleo, and some other diets that are out there that are pretty good. Encourage behavioral changes, so increasing activity, lifestyle modification, as I discussed, and then discuss the oral hypoglycemic agents that are given. All right, so let's talk about DKA, diabetes ketoacidosis. And this is how most kids know that they are diabetic. They'll come into the hospital, they'll complain, the family will complain that they've been having increased thirst, maybe using the bathroom a lot. They seem like their level of consciousness is changing. They seem to be a little bit more confused, lethargic, and they come in. And then diabetic ketoacidosis is usually confirmed when a glucose is greater than 200. So ketonuria or ketonemia, which is a serum bicarbonate level, less than 15 milliequivalents per liter. There are also 3 levels of acidosis to consider. Mild DKA, which is considered 0, is a venous blood pH of 7.2 to 7.3. Level 1 is moderate DKA, which is the venous blood pH of 7.10 to 7.19. And number 2 is severe DKA, which is the venous blood pH of less than 7.0. So DKA is complex, and what's quite interesting with kids is that usually kids who are just slightly over 200, even in the 3s or 4s, that's pretty good. And often those are not the kids that you're going to see come into the emergency department or come into the hospital. I have seen kids at 800 to almost 1,000, and they're still talking and they're still with it somewhat. And they come in DKA. And so you have to remember that care is done on a gradual. You just don't drop their levels quickly, because that can cause some neurological deficits. And so some of the precipitating factors that you, the nurse, must assess for is poor compliance with insulin regimens. Sometimes you'll see these kids come back secondary to that for DKA if it's not their initial diagnosis. Patients entering puberty and beginning of their menstrual cycle, you'll see those kids often. They might come in during that time. Caregiver lack of competence regarding insulin management. And so we call this neglect. And it's not that they might not love their child. They just can't. Maybe it's because they have some cognitive deficits or some other things going on. And so often when that occurs, you might have to involve the protective service team and to look at ways, how can the family be better supported? Or is there an alternative that can be put in place? That the child receives the medical treatment that they need. Insulin pump failure might be another cause. Insulin that is out of date, and underlying illness or surgery or trauma, that DKA becomes a secondary cause. So signs and symptoms in kids, you'll see in particular toddlers, the classic is fatigue. They'll feel just generally sick, nausea, vomiting, abdominal pain, polydipsia, polyuria, polyphagia, and you could just read through this list. You might see some hyperventilation, such as with Kussmaul respirations, and this is usually when the child is more obtunded and almost comatose when you would see that. Signs and symptoms might be increased capillary refill time, poor perfusion, lethargy, weakness. Fruity odor of breath is common, of course, one of the hallmark signs. Confirmed by the blood glucose that's greater, it says here 250, 200, 250, and the blood pH is less than 7.34. That indicates degree of acidosis. So nursing care is based on 4 essential physiological principles. You want to restore the fluid volume, have the child to return to the glucose utilization state by inhibiting the lipolysis, replace the child's body electrolytes that are missing as well. And you're going to do this on an ongoing, steady basis, correct acidosis and restore acid-base balance. So what this looks like, it plays out at every hour on the hour, the glucose levels are taken. They're examined. The actual insulin dosage is then titrated. They're on a drip. that they're given and is titrated in response to what their labs are showing. Assess the child's frequently, rapidly, rapidly, and accurately. And so even at times when they first come in, your assessments might be every 15 minutes, then it might advance to every 30 minutes, then to every hour once they're somewhat stabilized. Expect rapidly changing intravenous solutions and adjust the plan before one therapy is completed. And so that means that they'll also receive some regular fluids to correct the electrolyte imbalance and dehydration. Observe and document child's response to each intervention. Know the sound of Kussmaul's. Hopefully you guys do know the sound. If you can, go and look it up online. Some people equate Kussmaul's, and I'm just telling you this. It's usually, they'll call it the death rattle. It's very distinct. It's like a rattling in the chest that you can hear, and it's very audible. But it's not just present from the chest. It also emits from their breathing, from like their nares in their mouth. So go on Google. You guys are pretty good at Google. Go on and Google it so you can hear it if you've never heard it before. And then you want to keep parents informed as much as possible. So education, explaining every step of the way what is happening with their child. You're going to tell them ways to prevent DKA. Teach the family to check and recheck the blood glucose levels or the urine ketone levels, so they'll get the little sticks that they'll have to use at home as well, especially when the child is sick. That is going to be important for them to be hypervigilant with monitoring their child, just to make sure that their blood glucose level is not exceeding 240. Make parents comfortable with the child's management plan before discharge. You definitely want to do that, and make sure that they can do effectively those return demonstrations. And then you want to help the family plan meals and insulin administration. This is just not done in isolation. Often they're followed up on an ongoing basis for a while with endocrinologists, especially if they're at a ped center like Lucille Packard or UCSF Children's. They're followed up that way, and they'll have the dietitian, the nutrition and clinical nutritionist who's a part of that interdisciplinary team. Inform parents on the importance of maintaining normal blood glucose levels and to avoid long-term complications. So that is the conclusion. Let me know if you have any questions. All right, thanks.